Okay, now we continue with the mood disorder and somatoform disorder. This topic is very important as it will come out in both MCQ and as well as MEQ. Yeah. So, what is bipolar mood disorder? So, when a person has experienced at least one episode of manic and another episode of depression, so we can diagnose the person with bipolar mood disorder. So let's say for the first episode, the person presented to the psychiatrist as having depression. So the first diagnosis will be major depression, not bipolar mood disorder in depressive phase, unless the person has a previous episode of manic. Then we can diagnose or we can identify this client has bipolar mood disorder. Otherwise, if it is just first time depression or maybe the next episode manic, then the doctor will change the diagnosis into bipolar mood disorder. For bipolar mood disorder, the thought, the mood and the behavior swings from the normal into the depressed phase. Yeah. So to the grandiose, from the normal to the grandiose, or from the normal into the depressed phase. So from before the onset, we know about the personality of the individuals, the mood of the individuals, but after the onset of depression, we know there's a change in the mood, there's a change in pattern of behavior, pattern of sleep, eating, and so on. Yeah. So in bipolar, we have type 1 and type 2. The most common that you will find in the ward is the bipolar type 1, consists of depressive episode as well as manic episodes. In comparison to bipolar type 2, there's a depressive episode and hypomanic episodes. Hypomanic is not that severe as compared to the manic episodes in terms of the duration of the manic. So for the hypomanic, the duration will be around 1 day to 4 days only, not up to 1 week. Okay. So for bipolar type 1 having the manic episode, uh, it is noticeable that the mood disturbance has been presented by the client for 1 week period. Okay. And with the three of the symptoms at least, such as inflated self-esteem or grandiosity. So there is a sense of superiority, a sense of self-importance as compared to before the onset of the manic. And there is a decreased need for sleep because during these times of manic excitement, the person has a lot of ideas and a lot of energy. That's why they have less need for the sleep, and they are more talkative than usual, and they have pressure to keep talking, or we call it as pressure of speech, because they have a lot of ideas going on in their mind. We call it as flight of ideas. Okay, there's a lot of ideas. So during this episode, the person may have suddenly think about few things, few ideas, few innovation, few creative songs, for example. Yeah, few dramas. They can create dramas, create novels based on these ideas, and they are distractible. They have a poor focus. And number 6, they have increase in goal-directed activities, such as they become ambitious to do certain things. So, for example, like do the direct selling, involved in business, and use a lot of money for business, for example, for investment. And also they have psychomotor agitation, or we call it they become restless or hyperactive. And number 7 is they involve excessively in the pleasurable activities. For example, go to the pub for social drinking, go to the clubbing, karaoke, and so on. And they have high potential for painful consequences associated with it, with these pleasurable activities involving uh, taking alcohol while driving. Yeah. And for I would like to go short for this management of bipolar. For the psychopharmacotherapy, due to their many excitement, we need to control this hyperactivity with antipsychotics to taper down their behavior and so on. And we also need to administer mood stabilizer. So we have lithium carbonate is a form of salt, the garam. So only those who comply with the treatment can have lithium carbonate, because it can become toxic if it is and need frequent blood monitoring. But for this lithium therapy, it can maintain the mood for quite some time, which is quite efficient. And we also have other mood stabilizer, carbamazepines, or the trade name is Tegretol, or sodium valproate, which is actually they are anticonvulsant, or epilim. It's the same drugs that we prescribe to those with epileptic or a seizure. In those in depressed mood, we need to prescribe with they need to be prescribed with antidepressant. And another therapy for them is psychotherapy, can be in terms of individual or group therapy. And for those with severe manic, like to control their excitement, hyperactivity, and because of they don't comply with the medication, and we need to intervene quite fast. That's why the doctor will prescribe the ECT. And those who is in a suicidal attempt or suicidal ideations, and the drug antidepressant will also take some time. That's why we need to proceed with ECT to complement the intervention. And for the common nursing diagnosis for bipolar disorder is the related to the episode of mania. This is very important for you guys to remember that they have the risk for self-harm or injury due to their hyperactivity and impulsivity, and most of the time they are admitted to the ward because of being aggressive, violent at home. So this is the priority nursing intervention for them. It is very crucial in the MEQ, guys, that we provide the scenario, and you need to formulate which one is the priority nursing diagnosis according to the scenario. So if let's say patients comes or brought into the psychiatry because of aggressive, have a conflict with the family members before they were brought to the hospital. So you need to remember that there is another risk for self-harm or injury or violence in the ward, which we as a mental health nurse need to closely monitor this kind of client for the risk for violence or self-harm. Yeah? So second important in diagnosis would be the risk for violence directed to others, related to impulsivity or irritability, imbalanced nutrition, less than body requirement, related to decreased interest in food, or related to hyperactivity. It can be the case where they forget to take their food because they are busy with something else. They have altered thought process related to flight of ideas, as evidenced by patients keep on telling blah blah blah, or impaired social interaction related to excessive talking, and disturbed sleep pattern related to decreased need for sleep. So if there is a long scenario, but bear in mind which one is more risky and need more close attention, which is the first two. So you need to formulate the nursing diagnosis according to the priority. Yeah? You can just forget about all the sleep pattern, all the social interactions, but the priority should be given for the risk of for violence or risk for injury, for example. Yeah? Okay. So, I believe that for the risk of injury or risk for violence, you can refer to my previous lecture. I think in the my second lecture, we can go back to about the risk for aggressive behavior. And for the major depressive disorder, so bipolar, we have manic, we have depression. For major depression, bipolar mood disorder in depressive phase need to follow the criteria or the symptoms as in major depressive disorder. So, in the criteria, it say that at least 5 or more of the following symptoms have been present during the same 2 weeks period. That means over the 2 weeks period, persistently the patient has a change in the previous functioning, which is marked by a depressed mood most of the day, which is like almost of the day from morning until night, and markedly diminished interest and pleasure in all activities, like for example in the daily activities, they don't have the desire to watch TV, listen to music, go to bathroom for their hygiene needs, for example, or go outside for eating. Yeah, so there's a marked diminished interest. And there's a significant weight loss when not on diet, or maybe weight gain, and that's for certain patients only. And number 4, there's insomnia or hypersomnia nearly every day, where the patient become inactive and they feel that they just want to sleep all day. And number 5 is the psychomotor agitation. Like for some clients, they tend to become restless, like patients with anxiety, or retardation. Retardation means that the movement is very slow. It's very difficult for them to drag their leg to move from one place to another, even to the bathroom. Yeah, the movement is very slow, and there's a fatigue or loss of energy like every day, feeling of worthless or excessive or inappropriate guilt. This one is very crucial because patients tend to have suicidal ideation associated with the feeling of worthless and excessive guilt, and diminished ability to think or concentrate or become indecisive. This is a very common or a typical presentation of a patient with depression. They are not focusing on the task. If you see them reading or doing some task, they are very slow because of their retardation as well as their thinking process, which become very slow. That's why in the rehabilitation activity, we need to be patient with these depressed clients, because they will be very slow in coloring, in doing their tasks. For example, doing the craft, they are very slow. And lastly, recurrent thought of that or suicide ideation or suicidal attempt, which is put patient at risk for another suicidal attempt in the hospital, which we would like to be cautioned on this. And depression in the elderly, you need to be aware, guys, that due to increase in aging population nowadays in Malaysia, and our elderly, they are poor in technical or social, using social media to communicate with the other family members. So also due to low socioeconomic status, they live in the rural area, far from the other facilities, far from the hospital, from the other family members, like in Felda, in Lipis, for example, in Jerantut, the loss of spouse, like the death of spouse, make them live alone in the house, in the kampung house, and they have illness, hypertension, diabetes mellitus, for example, yeah, or maybe minor stroke, and they are isolated from the others due to the physical distance of the house. So this will make the elderly tend to get depressed, and their depression is more to seeking attention in terms of verbalizing their complaints of the body sickness, having headaches, having muscle stiffness. Yeah, they make complaints in terms of their body, which we call it as somatic complaints. But they don't have the exact depression punya feature or characteristic, which is suicidal ideation, suicidal attempt, low concentration, no. But this is common nowadays, and we need to pay attention to this issue of depression. And for the pharmacological management of the patient with major depression, we need to prescribe or administer tricyclic agent like imipramine, amitriptyline. So you need to remember about these first drugs, or the old drugs. It may come out in the MCQ. And a quite modern antidepressant drug, we have SSRI or selective serotonin reuptake inhibitor like fluvoxamine, or the trade name is Luvox. We have fluoxetine or sertraline. We have SNRI or such as olanzapine or MAOI inhibitor, meclobamide. Yeah, but certain drugs like tricyclic drugs may come out in the exam. We will test you for certain drugs. For example, like lithium, yeah, it may come out in the MCQ. So for the psychiatric management for depression, we can provide psychotherapy or counseling if they experience certain losses or a certain worry, and also ECT if they are unresponsive to medication, because we need to remember that during the first 3 days or maybe day 4, day 5, patients still not showing any good progress after taking the medications, because medication takes some time to produce the therapeutic, how to say, therapeutic actions to the body. Yeah? And these are the common nursing diagnosis for depression. The priority one is the risk for suicide related to feeling of hopelessness. So about the others, you can read on your own. So in the MCQ, for example, we will provide statements about client expressing negativity and so on. So you need to pick which statements belongs to patients with risk of suicidal ideation, risk of suicidal attempt, for example. Yeah? So I think you need to go back to my previous lecture. So there will be a lot of questions, or maybe 2 to 3 questions about suicide, suicide management and so on. And moving to somatoform or somatic symptom disorder. This is the disorder which manifested instead of psychological symptoms, they presented as the body symptoms. So, for the somatoform, it is diagnosed when the person has a significant focus on the physical symptoms such as pain. It may mimic with the back pain, for example, or chronic pain, weakness or shortness of breath, like similar to asthma maybe, or to a level that results in major distress or problems functioning, which they believe that they have medical issue, and they tend to absent from the school, from the work, and they tend to seek medical advice. So the individual has excessive thoughts, feelings, and behavior related to the physical symptoms. Like I said, most frequently they tend to absent from the schools. They tend to say to the other people, complain about their body symptoms, and these physical symptoms may or may not be associated with a diagnosed medical condition, such as the person may believe that they have asthma, but there's no evidence about or there's no previous diagnosis about asthma in these patients before this year. Yet, the person is experiencing the symptoms as if the symptom is real. For example, maybe they believe that they have minor stroke and believe that they are sick. They are not faking it. They really show the symptoms, yeah. And the symptoms are characterized by excessive thoughts. These thoughts is like they've been preoccupied with the thoughts of the sickness, the illness experience, and the feelings and behaviors related to these somatic symptoms. And it is associated by at least one of the following, which there is persistent thoughts about the seriousness of one symptoms, which they believe they need to go to emergency department immediately, and there is a persistent high level of anxiety about this health issue. Excessive time and energy devoted, like they went to the hospital for a thorough checkup, for example. They believe they have heart attack, for example. And although any one somatic symptom may not be continuously present, the state of being symptomatic is persistent. Typically, it presents or the client believe that they have the symptoms for more than 6 months. It tend to prolong. And for example, I provide you with this example. Miss Sarah suddenly experienced sudden and severe paralysis in the legs with no apparent cause. This is a real story which I happened to witness myself while I was posted at a hospital Ipoh at the psychiatric clinic, and during the consultation, this woman was brought with using wheelchair accompanied by the husband, and the reason of this paralysis, sudden paralysis without any previous history of hypertension, is due to her excessive worries about her cousin who just divorced with the husband. This is about the cousin, not about herself. But due to this worry, sympathy, over sympathy with the cousin situations, she manifests this distress with symptoms of paralysis. Okay, and for this reason, Sarah undergo extensive medical examinations, including neurological tests, imaging studies, consultation with various specialists. But uh, until we meet with, she was brought to the psychiatrist, then we know there is a psychological reasons underlying this paralysis. And for the management, we need to provide talk therapy for the individual to express the feelings. And individual can help to change their thinking and behavior. And it also the individual will learn ways to cope with the pain or other symptoms and deal with the stress and improve functioning. So don't be surprised if you meet an individual who always complain about having maybe headache, having painful back, for example, painful leg, or maybe they believe they have pneumonia or asthma or severe allergies, due to unapparent reason, but it could be psychological in nature. And for health education, we need to make the client understand about the mood disorder, treatment, plan, risk, and promote early recognition of the signs and symptoms, and teach coping strategies and healthy lifestyles, and encourage help-seeking behavior, because nowadays we have a lot of a hotline where 24 hours the patient can seek counseling help through phone call, especially for the suicidal ideation.